Hey everyone, thanks for inviting me. It's a pleasure to be here. Um, I represent School of Biomedical Engineering and Imaging Sciences at King's College London. Digital twinning that we do is slightly different, as I just realized from everything we heard earlier today. So I will specifically talk about how cardiac digital twins can be used to stratify, meaning classify patients per categories, and also to guide therapy in a patient. I will consider a very specific problem, but it's a very common problem. Atrial fibrillation, or AF, is the most common arrhythmia. It affects roughly 2 out of 100 people in the UK annually, and similar statistics in the rest of the developed world. And it's associated with the lifelong morbidity, increased risk of mortality, 6 times increased risk of stroke, 5 times increased risk of heart failure, and so on. And it comes as a huge burden on NHS. Almost 1.5% of entire budget of NHS is spent on this one condition. Given that there are hundreds of different cardiac conditions, if you multiply it, it probably will scale up to about half of NHS budget is spent on cardiovascular disease. Actually, cardiovascular disease is more expensive than all cancers combined. And here is an illustration what happens during atrial fibrillation. Atrial fibrillation affects the upper chambers of the heart. Normally you have a cluster of cells called synatrial node that sends once a second sends a signal that ensures that your heart contracts regularly 1 beat per second. But in atrial fibrillation, this pattern is completely lost because some unusual locations in the rest of the heart start emitting waves when they shouldn't be emitting waves. And the video also illustrates how it can be treated. This is the only curative treatment because what you do, you identify these unusual locations that send unusual electrical signals, and you burn tissue around them using a catheter, after which the heart restores its normal function. This procedure is called catheter ablation. Right, so any other treatment, such as drug treatment, just suppresses symptoms but doesn't treat the condition. So this is the only curative treatment. And the disadvantage is that it's highly empirical. It just targets some statistically significant areas that are most likely to emit these waves. But per patient, we don't really know where these areas are. And therefore, about half of the patients come back for additional treatment in 1 year's time. So if we have several million patients, it means that hundreds of thousands of patients will not respond well to this procedure. And what we're trying to do to improve these statistics. So as I said, I understood that digital twin mean different things to different people. This is what we mean by digital twins. Digital twins, first and foremost, is a collection of data from a patient or from ex vivo experiments that we can use to reproduce what happens inside the actual heart. So here is in the middle is, well, not the entire heart, 2 upper chambers of the heart, right and left atrium. And this is the cluster that sends our normal heartbeat once per second, the synatrial node. So we need to have good knowledge of how synatrial node works. We need to have even orientation of individual cells within synatrial node. It's a very small piece of tissue. It's about this big. We need to know how electrical action potentials develop inside synatrial node. Then in order to personalize this model to patient data, we need to have multiple scans from patients. We need to have scans that show very intrinsic details of cell and fiber orientation inside the heart, biopsies that show different types. For example, blue here is the synatrial node, and the working myocardium is in red, so you can all gauge it from experiments. Then you need to have patient-specific scans that are non-invasive, such as MRI scans, and you can get detailed structure of the heart, detailed structure of the body. I will explain in a minute why we need body as well. And then some pathologies within the heart. I will focus a lot on fibrosis today. Fibrosis is a collection of collagen tissues inside the heart that prevents myocardium from contracting. And again, you can get it from MRI. And then you kind of embed all this data in your model of the heart. And then moreover, you want to go to the next level, to the next scale of the entire body, because most of the signals that we can actually record from a patient are not invasive. They are not from the heart, they're from the body surface, and that's electrocardiogram. So we want to link what happens inside the heart with what we can record on the body. So therefore, the digital twin is collection of a lot of images from the patients because they're easy to collect, they're non-invasive, and a lot of clinical data and records that record history, disease history in the patient, record signals such as ECGs, record blood tests, biopsies, and so on. And then on the other side is what we use to analyze the data and what we use to link up the data, because if you only have images, you only have electrograms, we don't know what is the link between the structure and then the function that we record from the body. So what we use is a biophysical model, which is a set of equations that is based on physical and biological laws and allow us to track the phenomena inside the heart and inside the body. And then we also use statistical models, and the advantage of statistical models and AI is that they're much faster than biophysical models, and I will elaborate on it slightly later. So we will be focusing on atrial fibrillation and the atria. And I mentioned the importance of fibrosis, and this is illustration how we know some information from images of the heart. We know some information from clinical records, but we don't know the relation between them, and we use digital twin to fill in this gap. So what do we know from the image is that if we take MRI image of the heart, this is just one slice through the body, we see that the two atria, upper chambers, are clearly visible in the image. And then the bright white areas are the fibrotic areas. This is dead tissue, collagen. And if we slice by slice reconstruct shape of the atrium, we will see that there are big areas of fibrosis that develop during atrial fibrillation. And we can classify the patients, that's what stratification is. We can classify the patients based on how much fibrosis there is in the heart. And if you are healthy, you have less than 1% fibrosis, your heart isn't really damaged. If you have been in atrial fibrillation or some other related conditions for many years, you have over 35% of fibrosis, so your heart is really, really unhealthy, and then there are some intermediate stages to it. So this is images. Now, if we look at the patient history, what we see here is that all patients, this is based on several hundred patients, all patients were ablated, so they underwent procedure that I showed in the first slide at time 0, and they were followed up for 2.5 years. 1.5 years. And this is a proportion of patients in which the arrhythmia came back after 1.5 years. So we can see that in stage 1, very little fibrosis. The procedure is highly successful. About 15% of patients come back after 1.5 years. But if your heart is really unhealthy, and we see it from the image, almost 70%, that's huge proportion of patients will come back. But why this happens, we don't know, but we can try to understand this using modeling and using digital twins. So this is a workflow that can be used to create such models. We start from MRI images from a collection of patients I mentioned in the clinical trial I showed before. There were several hundred. We can create several hundred models based on several hundred images. From each image, we reconstruct wall of the chamber of our interest, in this case, left atrium. From the color of the signal of hyperactivity in the image, we can reconstruct areas of fibrosis. They are also clearly visible, and we already know how fibrosis is important in outcomes for the patient. And then we can simulate electrical signal and how it propagates inside the heart. I will show the videos in the next slide. But the important point is that if we know how electrical signals propagate in individuals' patients' heart, we can figure out what are the patient-specific areas, they are shown here in yellow, that are most likely to harbor these abnormal signals. And if we know where they are per patient, we can ablate per patient rather than use some one-for-all approach, and they therefore improve the outcomes. So here are the videos. So this is the left atrium, and this wave is an arrhythmogenic wave. It's called the rotor. It has frequency of about 10 hertz, 10 times higher than your normal heartbeat. We can use some sophisticated methods to identify exact trajectory of this wave, and therefore we will know exact location of this wave. And then we can tailor ablation procedure to this specific patient. So we ablate the standard statistical areas, pulmonary veins, but then we ablate this very circuit seen in the simulation and try to reinitiate arrhythmia. And we can see that wave can propagate. It just hits this obstacle that we created and dies out. And in simulations, if we can run this for many patients, we will see that statistically it works 100% of the time. Of course, life is more complicated, but at least in the model, it's highly successful. What are downsides of this approach? First is electrophysiological data from patients is limited. So we simulate these waves inside the heart, but we don't have clinical validation most often. We don't know what actually happens inside the heart. And second is that this model is really expensive. Even if it is run on a supercomputer, it takes hours, up to 10 hours to run one simulation like this, and we need to run it for hundreds of patients. So the next steps I will go through is how to overcome these two limitations. So case study one is overcoming first limitation of not having enough patient data. And I already mentioned ECG. This is really cheap. It's available in any hospital, pretty much for any patient. You collect 12 listed ECG data. You just put 12 electrodes on the body surface, and you collect signals like this. And the question is how these signals are linked with waves inside the heart. And again, in a clinical setting, you cannot evaluate this, but using a model, using the digital twin, you easily can. Again, you generate a model based on patient images, you run the simulations, you solve so-called forward problem from the simulation. If you know where the wave is in the heart, you unambiguously can figure out what the ECG is. There is one-to-one correspondence. And then you want to solve the inverse problem, because in real life, that's what you have, and that's what you don't have. So you measure ECG from a patient, and from ECG, you try to predict where the origin of the wave is, where do you want to ablate. And mathematically, the inverse problem is ill-posed. There is no unique solution. But what you can do, you can use some statistical algorithms, and our old work, we just used a simple decision tree to try to figure out from shape of ECG what is the origin, and even with such simple approach, you get 89% accuracy, and it was more than 10 years ago. Since then, AI occurred, and I will explain how we're using AI to increase the statistics. So case study two, how we can use AI, so far not about ECG, but about something else. Again, we simulate these models based on images. We find the areas per patient that harbor electrical waves that we ultimately need to ablate. And I said that the second limitation is that these models are really expensive. We cannot run this for hours, and especially if you want to do it in the hospital, most hospitals don't have supercomputers. They need to run it on a laptop basically, and then it becomes impossible. So what you can run on a laptop, if you have an AI algorithm, you can run it in 30 seconds. So what we need to do is to train such an AI algorithm. So what we do here, we use both the image and the prediction from the model, and prediction of the model can be just used as a label for the image. So we feed to a convolutional neural network an image plus label saying for this patient you need to apply treatment strategy 1, for another patient strategy 2, and so on. And then the network during training predicts what strategy needs to be used. So in training, you give both types of information. And then in testing, the beauty of it, you can remove one type of information. You don't give the prediction of the model. You don't need model anymore. You just give an image, which is cheaply available. Most patients are sent for a scan before their procedure anyway. So you just give an image, and the model from image alone gives with same 89% accuracy correct prediction of what therapy should be used per patient. So now we want to combine the two approaches, cheap information available from ECG, cheap information available from images, and the efficiency of AI in making these predictions. So first step would be to create very detailed digital twin for large number of patients, and not only the heart or the specific chambers of the heart, but the body itself, and you will need to account for different organs that hinder spread of current between the heart and body surface, such as lungs, bones, and muscles, and so on. But we already have tools to do this, and these models are working. So you create the heart plus torso model, and you link up activity in each patient's heart with specific pattern of ECG. For each of these patients, we also have ECG recordings, so we can actually validate parameters of the model using patient ECG recordings, so we can feed parameters pretty accurately. And therefore, we can ultimately create fused data sets which contain images and model predictions per patient. And we can use augmentation techniques to create thousands of these data sets. Next step is the training. I already explained how it works. So in training, you use the data set, which contains all types of information, the image itself, prediction of the model, prediction of where do you need to ablate, actual suggestion of what specific ablation strategy to use to ablate it, and ECG. You train the network, and the network says that here is the bad guy, you need to ablate here, and your best strategy is strategy X. All right, and then after it is trained, you kick out the model out of the equation. You just give it whatever data is available. You can give either MRI image if you have MRI image, or ECG if you don't have MRI image, or if you have both, give both, whichever you have. And based on any patient information that you give, you should ultimately get same accuracy. So our target accuracy is to exceed 90% prediction. And then finally, if we manage to do all this, and as I said, we already are somewhere in the vicinity of 90% accuracy, there are software systems that are used for therapy guidance. One of our collaborators is a company called ADAS 3D. What they do, they just present during clinical procedure, they just present information to a clinician in a way that helps them to perform ablation. So rather than doing ablation blindly, but just guiding catheter somewhere inside the heart, they see image of the heart, they see how much fibrosis the patient has, so they can navigate the catheter around the image itself. But what is missing in the current guidance system is the functional information. We see the structure, but we don't know where the wave is. So what we're doing is to to enhance the system, adding ECG information, adding our trained AI to the system. So when clinician uses the system, they see not only structure, but they actually see what is the most likely area that needs to be ablated, and they also get a prediction of exact strategy that you need to use to ablate it. And if we so it's an ongoing project funded by British Heart Foundation. When we complete it, we hope that we will create a clinical decision support system that will be very cheap to use because the information, clinical information, comes at no expense. It will be efficient. We already have prototype, and it runs 30 seconds to make this prediction after the training is complete, and therefore it's compatible with clinical workflows. The clinician just can press a button, see the image, and then have an informed decision how to treat the patient rather than semi-blindly. Yeah, and final conclusion is that digital twins can be used first and foremost to establish robust links between atrial structure and function, and that's what we want during clinical decision making. But then in order to make these predictions efficient, we can use AI to help identify patient treatment strategies on the side and very quickly and very cheaply. Thank you.
Thank you very much.
Thank you. This is fascinating. Very nice. One thing that I was thinking about here was the accuracy. If you said that you had a smaller patient pool, how do you know that 90% is accurate with respect to what?
Right. Yeah, very good question. So the beauty of AI is that it can be retrained, right? You don't need to each time create a new network and train from scratch. So we start with small pool of patients, but then as we get more and more data, the same network gets retrained until the pool basically becomes
I see.
Unlimited.
Does this get you into trouble for certification? Because imagine if you tell the clinician with that accuracy and the clinician goes ahead and burn the heart at the wrong place 10% of the time and kills, right. I don't know.
Yeah, so, okay, so there are some dangers in this procedure, but it's really unlikely that the patient will die. So we are talking about increasing accuracy from 50% because it's highly empirical. Basically, they have no information whatsoever. So having so much extra information to increase this accuracy to 90 plus. And yeah, as I said, there is no danger of patients dying about this procedure. The only danger is that they still will need some treatment afterwards.
Right, because it's decision support, then
yes.
It's self-certified, I see. Very nice.
Thank you.
So thank you also from my side, super interesting stuff. Also for personal reasons, my mother has AF. So that she's being treated with medication because they were not really sure about what to do with the ablation at her age. Is this also supposed to guide also reasoning? I mean, if you can actually derive essentially confidence in the outcome of the ablation procedure, for example, then this would also, is this planned to help decision making also in medication versus intervention?
Very good. Thank you. The system is explainable in two different ways. One way is that the model is explainable because what happens in the model is completely tractable, and you understand why you need to ablate in a certain place. But if you only are using AI, we also have another workflow, which I didn't show, to use explainable AI to try to open the black box and understand why AI makes this specific prediction. In terms of medication, it's a very interesting case that you mentioned, your mother. I didn't say that, but some patients simply will not respond to ablation. and also what our system will do. Again, I didn't mention it, but it's embedded in the system. One of the possible strategies saying is not ablate here, here, or here, but saying this patient is beyond ablation, don't ablate. So identifying non-responders, it's also a huge problem. So the system will address it. And then finally, it's a very good point that we should think of embedding other medications. So basically saying, unless all strategies work, what's the next best strategy? I think we really need to think about it. Thank you.
Excellent. Thank you.